Hello, everyone. I'm Kanwal Raghav, one of the associate professors in GI Medical Oncology at the University of Texas MD Anderson Cancer Center. And I'm here today to talk to you about the role of HER2-directed therapy in treatment of HER2-expressing GI cancers. So today we have on agenda to understand the HER2 prevalence in patients with advanced GI tumors. Please make note we are going to talk about GI tumors beyond gastroesophageal cancer, which in itself is a different topic. So we'll be essentially talking about metastatic colorectal cancer and metastatic biliary tract cancer, and then the impact and role of anti-HER2 therapy and the developing paradigms regarding both these cancers. When we talk about HER2 prevalence in colorectal cancer, HER2 is a small but distinct subset of colorectal cancer. This is seen in anywhere between 2 to 3% of all unselected colorectal cancers. And it presents certain unique clinical phenotypes, such as more preponderance of lung metastases, increased incidence of brain metastases, and also non responsiveness to anti EGFR based chemotherapy regimes, which are the standard of care for these patients. There are two ways of testing this: immunohistochemistry and ISH, and then next generation sequencing, which has become commonplace nowadays. Whenever you look at both these modalities, you find that the incidence of HER2 positivity is about 2 to 3% in unselected cohort, but HER2 overexpressed or amplified tumors are found mostly in RAS BRAF wild type patients, where the incidence goes up to about 5 to 6% compared to RAS mutant patients, where it is only about 1%. And this is an important clinical implication. So, in this large colorectal landscape, you can see that it represents about 2 to 4% of all colorectal cancers. In biliary tract cancers, the incidence of HER2 prevalence changes with where the tumor is within the biliary tract. The highest concentration of HER2 overexpressed or amplified tumors is seen in gallbladder cancer, where this amplification is seen in about 15 to 20% cases. It's also seen in perihilar cholangiocarcinoma, but the incidence decreases in intrahepatic cholangiocarcinoma or extrahepatic cholangiocarcinoma. You can see that when you look at common NGS prevalence estimates, there is a significant difference of alteration frequency, gallbladder being much higher than intrahepatic cholangiocarcinoma. And this is the broader spectrum of how HER2 spreads across all advanced GI tumors. The top four arrows, in fact, the top five arrows are usually dedicated to gastroesophageal tumors, where incidence can vary anywhere between 25 to 30%. But then there are a smattering of these lower GI tumors, such as colorectal, pancreas, cholangio, and biliary tract cancers, where also HER2 amplification plays a role. So once we've defined this prevalence, what is the current role and the emerging data regarding use of anti-HER2 therapy in these tumors? And I'm going to talk specifically about metastatic colorectal cancer and then metastatic biliary cancer. So the first thing that we learned about metastatic colorectal cancer through preclinical experiments was that single agent anti-HER2 inhibition doesn't really work in these patients. So because most of these tumors were enriched in the RAS wild type population, where you used to use anti-EGFR, the first thing that you find is because of the crosstalk between HER2 and EGFR, which is actually HER1, there is very limited benefit of anti-EGFR in these populations. So this PDX, what it shows you is when you have HER2 amplification, you do not respond to anti-EGFR agents. But when you give somebody dual anti-HER2 inhibition, so two anti-HER2 drugs, that's when you get the maximum bang for buck. And this has important clinical implication as compared to breast cancer and gastric cancer, where single agent anti-HER2 therapy is quite effective. Following up on those preclinical experiments, the Heracles A and My Pathway study, which were done in Europe and US using trastuzumab in combination with either lapatinib or pertuzumab in a heavily pretreated population, showed robust responses that lasted for quite some time in this heavily treated patient population. So in the Heracles study, the objective response rate was about 30% with the median PFS of about 5.3 months. In My Pathway study, how it differed from Heracles study was Heracles only included patients with RAS wild type tumors, whereas My Pathway allowed both RAS mutant as well as RAS wild type tumors. If you remember from the first slide, HER2 amplification is enriched in RAS wild type tumors, but it is also found in RAS mutant tumors. And one of the striking factors from this was that HER2 therapy worked very well in wild type tumors, but did not work in RAS mutant tumors. So dual anti-HER2 inhibition is restricted to patients with HER2 amplified RAS BRAF wild type tumors. The most updated data on trastuzumab and pertuzumab also showed similarly that colorectal, the response rates were about 31% in unselected population. But when you look at RAS wild type versus KRAS mutated patients, you can see the striking difference of 31% response rates in the wild type population compared to only 12% response rate in RAS mutated patients. So Mountaineer's trial was the pivotal trial that laid the foundation of the first FDA approval of an anti-HER2 therapy in metastatic colorectal cancer. This was based on the premise of dual anti-HER2 inhibition using trastuzumab and tucatinib. Tucatinib is a small molecular tyrosine kinase inhibitor of HER2. This was initially a single-arm study and then was randomized to trastuzumab tucatinib versus tucatinib alone. So single agent anti-HER2 inhibition with the primary objective of a confirmed objective response rate. So this is the results of this study. As you can see, again, tremendous responses seen in nearly 38% of all patients in the trastuzumab tucatinib arm. Compare that response to 3.3% response seen with single agent tucatinib. So single agent anti-HER2 inhibition should not be undertaken in patients with metastatic colorectal cancer. Patients that crossed over from tucatinib monotherapy arm also derived benefit when you added trastuzumab. A couple of lessons to learn from this is that the left-sided tumors responded better, and also patients with IHC 3+, which are the ones that are highest expressing HER2 tumors, were the ones that derived most benefit with a response rate of about 46%, and those with 2+ had a response rate of only about 20%. This was also a fairly well tolerated regime. You can see that in the entire cohort, grade 3 adverse events occurred in only about 38% cases, of which only about 7 to 9% were related to the treatment medications. And the AEs that led to study treatment discontinuation was in single digits, about 5.8%. And no deaths were noted. So overall, a fairly well-tolerated regime with diarrhea and fatigue being the major side effects that are seen. Now let's pivot to another class of compounds that is used in anti-HER2 therapy, very similar to breast cancer, where trastuzumab, pertuzumab, and tucatinib are used, and these are molecules that inhibit the axis, the HER2 axis. There is a new class of compounds which are antibody-drug conjugates. So think about antibody-drug conjugates as targeted chemotherapy, which uses HER2 as a homing beacon. And TDM1 is a classic example of that, which showed activity in breast cancer, but has not shown any activity in metastatic colorectal cancer. Trastuzumab deruxtecan, or DS8201, is a next generation antibody drug conjugate, which is linked to a topoisomerase 1 inhibitor payload. This is very similar to irinotecan, but a more potent topoisomerase inhibitor. This was evaluated in HER2 positive cases in the DESTINY-CRC01 study. This study had three different cohorts. Cohort A is what we call as classically HER2 overexpressed cohorts, which are either HER2 IHC 3 plus or 2 plus and amplified cases, very similar to the definitions that we use in breast cancer and gastric cancer. And then cohort B and C were HER2 low expressors, which were not amplified. Um, in this cohort, I would concentrate my efforts over the cohort A, because in cohort B and C, there were no responses seen with trastuzumab deruxtecan. However, in cohort A, which were HER2 overexpressors, you can see there was a confirmed objective response rate of about 45%. Remember, this was a heavily pretreated population. In addition to the fact that it was a heavily pretreated population, some of these patients had also been exposed to prior anti-HER2 therapy. And even in that population, this drug had similar response rates. Very similar to what is seen with dual anti-HER2 inhibition, you can see majority of these responses are restricted to the IHC 3 plus population, which are the high expressors, but very interesting and encouraging results nonetheless. The biomarker analysis of this study was even further interesting. So they did circulating tumor DNA analysis on some of these patients. Remember, these patients were RAS, BRAF wild type, which selection was based on the conventional wisdom that came from dual anti-HER2 inhibition. But when they looked at KRAS mutant patients in this cohort, they actually found responses. And the reason why these responses are probably occurring hypothetically is because this is more of a targeted chemotherapy, and thereby is not affected by how much the agent is actually inhibiting the signal. Because if that was the case, then the RAS mutations are downstream of the HER2 axis, very similar to why anti-EGFR drugs don't work in a RAS mutant population. However, it seemed like from this early data that antibody-drug conjugates could overcome that mechanism, and there were activity seen in RAS mutations. This led to the DESTINY-CRC02 study, which actually enrolled all patients that were HER2 overexpressed or amplified, irrespective of their RAS mutant status. It was also a dose optimization study to look at 6.4 milligram per kg dose and 5.4 milligram per kg dose because of the risk of interstitial lung disease with the 6.4 milligram per kg dose. And again, in this study, the lessons learned are this is an active agent. Response rates are close to 37, 38%. They were actually seen with the 5.4 milligram per kg dose, and it worked in IHC 3 plus population. It also worked in patients who had RAS mutations, and also worked in patients irrespective of the side where the tumor started. So this is how the ADCs are different from dual anti-HER2 inhibition. But again, a very active agent, irrespective of whether you've had prior HER2 therapy or not. Now, the toxicities of these antibody drug conjugates are very similar to the toxicities expected out of chemotherapy. You can find some fatigue, some grade 3 neutropenia, anemia, and thrombocytopenia. So, very much similar to what you would expect out of a chemotherapeutic agent. But the main side effect of interest is interstitial lung disease, which can happen with antibody drug conjugates. And you can see that with the 6.4 milligram per kg dose, that prevalence was about 12% compared to 8% for the 5.4 milligram per kg dose. And also in the 5.4 milligram per kg dose, there were no grade 3 or greater events seen, making 5.4 milligram per kg as the preferred regime for single agent trastuzumab deruxtecan in metastatic colorectal cancer. So I'm going to now pivot gears, move on to metastatic biliary tract cancers. Very much the similar line of development, but the agent that we are going to start with is zanidatamab, or ZW25. This is a novel bispecific HER2 antibody. So in a way, this is also a continuation of dual anti-HER2 inhibition strategy. And in metastatic biliary tract cancers, heavily pretreated, you can find there was a response rate of 38% in patients that were HER2 positive. This is a pan-tumor study, and you can see that there is response rates across the board. In colorectal, there was 38% response rate. In other tumor types, there was 36% response rate. But more specifically for biliary tract cancers, there was a 38% response rate and a clinical benefit and a disease control rate of 62%, with a median duration of response of 8.5 months. So a very promising targeted strategy for biliary tract cancers. This led to the Horizon BTC-01 study. This was an expanded single-arm study of zanidatamab given every 2 weeks. Again, you can see in 80 patients, it was spread across biliary tract cancer subtypes. As expected, gallbladder cancers was the major area where it was involved, but you can see these cases are also found in intrahepatic and extrahepatic cholangiocarcinoma. These are the results of this study. You can see a promising response rate of about 41.3% in a treatment refractory population, which would otherwise have no standard of care, with median duration of response lasting nearly 12 months. You can see that the responses were similarly seen across gallbladder and extrahepatic cholangiocarcinomas. There were slightly lower responses in intrahepatic cholangiocarcinomas, and the greatest group that benefits are the ones that have IHC 3+ or highly overexpressed HER2 tumors. Zanidatamab is also a well-tolerated treatment. You can see that serious treatment-related adverse events happened in only about 8% of this population, and the major adverse events associated with this drug are diarrhea and infusion-related reactions. When you look at infusion-related reactions and cardiac events, again, grade 3 or greater events occur in about 1 to 3% cases.
I was just curious if I could ask the waterfall plot that you showed before zanidatamab of the various tumors. It was interesting that it doesn't include breast cancer. And I've been asking the breast cancer people, I think there is data, but why did they look at everything but breast cancer?
So I think this has been it's a great question, Dr. Love. It's been sort of like the pattern of drug development of anti-HER2 therapies. If you look at it, the breast cancer by itself is a very big basket. And therefore, it's very easy to do breast cancer dedicated studies for HER2 drugs. Gastric also has a fair enough prevalence. More recently, lung cancer has come out as a different bucket, but the reason for that is lung cancer and the activity of HER2 is not really related to HER2 expression and amplification. It is related to more mutations. But when you bring that down to all other tumors apart from this, it is a smaller, important, but a small subset. And that's why many of these studies actually club all tumors, barring breast and gastric cancer. And this has been seen in other studies, including the ADC-PanTumor study of trastuzumab deruxtecan, which we will discuss in a bit.
And in terms of zanidatamab, you mentioned the clinical activity of the drug. What about duration of response? And also any other tolerability issues that come up using the drug?
Yeah, so the duration of response for zanidatamab from the Horizon study was close to 12 months. That is a long duration of response for targeted therapy in this tumor type. I mean, even first-line chemotherapy doesn't have that median duration of response for biliary tract. So I think that this is a story that you would see in colorectal as well as biliary tract cancer. Is when patients respond, they actually respond for a very good duration of time. And as compared to other standard of cares that are available to us at this stage in these tumors, the adverse event profile is actually fairly favorable. I think diarrhea has been an issue with both tucatinib and zanidatamab, as is the case with pertuzumab. But again, these are manageable side effects that can be managed with aggressive hydration as well as antidiarrheal regime to begin with.
What about zanidatamab in HER2 mutant disease? Does it cause responses?
The data in HER2 mutant disease is fairly limited with these tumors. One of the reasons for that is HER2 mutations occur across the spectrum of the HER2 molecule, and whether the mutation is occurring in the tyrosine kinase domain, or is it occurring in the juxtamembrane domain, or is it occurring in the extracellular domain, can make a lot of difference with regards to how the activity is. Now, for example, in lung cancer, most of the mutations that are found in the tyrosine kinase domain, but that's not the case for other tumor types. Now, there is some data about HER2 activity in mutant tumors, and I think we have a section dedicated to that, especially with regards to antibody-drug conjugates.
That's really interesting. Like, do the NGS reports actually say like anything about the type of HER2 mutation?
Yeah, so the details of the NGS report actually do mention it, but this is like a footnote that you have to see. So I think that's where
Right. Yeah, and they
HER2.
just say her. What I mean is, do they give you the interpretation of this HER2 mutation is the one that responds to ADCs or not? I don't know that they do, but maybe. The one
Yeah,
I've seen is just say between mutations.
yeah, correct. So, with HER2, it becomes complex compared to other mutations because, first of
Right.
all, you have to be very careful whether it is mutant or amplified, right? And an amplification in colon cancer may be important, but the mutation may not be that critical. On the other hand, in lung cancer, even in the absence of amplification, that mutation means you should treat these patients with anti-HER2 drugs. And then when it comes to the mutation, there are various kinds of mutations which one has to make a lot of effort to read through that and annotate it to see whether those are the mutations that actually respond.
It's really interesting. Please continue.
Thank you. So, going on from zanidatamab to trastuzumab to tucatinib, again, dual anti-HER2 inhibition. This is also in HER2-positive biliary tract cancer. This is a part of a basket study that was done for trastuzumab to tucatinib. Again, you would notice that all of these tumors exclude HER2 amplified breast cancer, right? I mean, yeah, there are mutations here, but these are not amplifications, whereas it allows overexpression and amplification pretty much all other subtypes, right? And what you would notice is in non-squamous non-small cell lung cancer, they allowed overexpression and amplification, but didn't allow mutation because there's already data regarding activity in mutations. So the primary outcome was confirmed objective response rate, but the cohort of interest for us is cohort 3, which is biliary tract tumors. And in this study with trastuzumab and tucatinib, you can again see a good response rate of around 46%, with duration of response being about 6 months or so. So again, dual anti-HER2 therapy showing benefit in heavily pretreated biliary tract cancers with HER2 overexpression or amplification. The side effect profile very similar to what was seen with metastatic colorectal cancer in the Mountaineer study. Diarrhea being the most common side effect, but the grade 3 diarrhea rate being still in single digits, around 5 to 6%. And then other than that, there are some infusion related reactions and fatigue. So this brings us to, since we are doing dual anti-HER2 across tumor types, we want to explore the activity of trastuzumab deruxtecan in HER2-positive tumors that were in all other cancers apart from colorectal, breast, gastroesophageal, and lung, because by that time there were already dedicated studies. So this is the pan-tumor study minus those tumors. And you can see that majority of these are GYN cancers, cervical, endometrial, ovarian tumors, which have high degree of HER2 amplification. But there was also biliary and pancreatic cancers that were included from the GI perspective. All of these patients got the 5.4 milligram per kg dose of trastuzumab deruxtecan with a primary endpoint of confirmed objective response rate. And again, very promising strategy across the board. This study, along with other studies in lung and colorectal cancer, are forming the basis of the FDA application for the first pan-tumor HER2 approval, hopefully. But what that showed you is that across the board in endometrial, cervical, ovarian, you can see robust responses. In biliary tract tumors, you can see those responses were mostly restricted to IHC 3 plus population. So 50% response rate in the 3 plus population, but no responses in the 2 plus population. In pancreatic cancer, though, the story is a little bit more dismal, that despite the fact that there was HER2 overexpression and amplification, there was no responses that were seen in this tumor. And you can see that when you look at these Kaplan-Meier survival curves, the median PFS for IHC 3 plus tumors is close to 7 months, compared to only about 4 months in 2 plus tumors. So again, most of these responses are restricted towards a higher HER2 expressing population. A quick mention about HER2 mutations. So, very similar to the T-DXd in HER2 overexpressed tumors, there was a pan-tumor study that involved HER2 mutant population. They subselected the mutations that they know have responded in lung cancer. So, these were all tumor types, and there were similar mutations in CRC and biliary tract cancers. But the response rates are low. They're not like as good as the response rates that are seen with HER2 overexpression. And also remember that there is some overlap between HER2 amplifications and HER2 mutations. So we don't really know what the HER2 expression level for these tumors can be sometimes, because there is definitely some overlap. But again, response is not very similar to the ones that you see in a HER2 overexpressed or amplified population.
So I know these are different diseases, but people can't help asking questions that come to mind. For example, in breast cancer, I think in general, people, once you're labeled as HER2 plus, they don't really differentiate whether it's I see 1 or 2 plus ish positive or not. They just sort of treat them all as HER2 positive. I don't know if there's data. It's kind of interesting and a little surprising to me, frankly, that you see less response with these overexpressors but fish amplifiers. Is there a theoretical or hypothetical reason why that might occur? And
Yeah, you bring up a very good point. Actually, it has been in a way, because prior to the advent of antibody drug conjugates in the clinical trial landscape, breast cancer was divided as HER2 positive and HER2 negative breast cancer. And the positives were what we classically called positive, which is HER2 IHC 3 plus or 2 plus amplified. And those were the ones that benefited from trastuzumab, pertuzumab, or a combination of that. There was no activity seen in HER2 low breast cancers. However, antibody drug conjugates have actually gone across that spectrum. Now there is a HER2 high expressors and then HER2 low expressors, which are the
sure.
ones that are not amplified. However, antibody drug conjugates actually show activity even in that cohort and actually has the FDA approval now in breast cancer. The same kind of activity has not been seen across tumor types. Even in this pan-tumor study, you can see there is a dramatic difference of the response rates that you would see with IHC 2 plus endometrial, cervical, or ovarian cancer, or bladder cancer for that matter of sake, compared to IHC 2 plus for biliary tract cancers. And we had already discussed how IHC 2 plus in metastatic colorectal cancer, the response rates are also single digit. So I think that there is something different about GI tumors in terms of heterogeneity. This could be related to chemoresponsiveness. It could also be related to yet yet not understood resistance mechanisms. So I think the field is developing towards understanding that, and that's where combination strategies of antibody drug conjugates will play a big role.
One other
Yeah.
thing I was going to ask you about is why do you think pancreas doesn't respond?
That's that's a great question.
I mean,
Pancreas is
it's
just
a
such a
ADC.
yeah, such a tough cookie, right? I mean, you would imagine that even with like 3+ tumors, you should have some response, right? Um, but first of all, like if you look at the distribution of HER2 positivity, pancreas generally tends to be low expressor tumors, right? So like for example, in this study you can see out of the 41 biliary tract cancer patients, 16 were 3+, 14 were 2+. But like in pancreas, only 2 were 3+, and 19 were 2+, right? So this is one of the reasons why I think that it's hard to like make assessment of like what exactly is the role of HER2 in pancreas, because we haven't been able to adjust for other factors such as what is the amplification rate, what is the IHC rate. Furthermore, pancreas is also a classic example of the fact where there is very minimal amplification rate in tumors. Even though there is expression of HER2, it's not as closely linked to amplification as it is in colorectal cancer.
And the other thing you were saying was in terms of mutations outside of lung cancer. I think it was colon cancer you were talking about. Where
Yeah.
what do you see there? Do they respond to T-DXd, for example?
So no, I mean, if
HER2
you look
mutant
at
CRC.
if you look at the pan-tumor study for T-DXd, you can see that the response rates of CRC and biliary tract was like 10 and 20%, right? So not as high, and this is a smaller number of patients. The other issue is because there is an overlap, right? So how do you know that, the reason why you're having these responses is not just because they're overexpressed in that population?
All right, please continue.
So this is again the side effect profile of T-DXd in biliary tract tumors, very similar to the side effect profile that we saw in CRCO1 study. Mostly the adverse events are related to bone marrow suppression, such as neutropenia, anemia, thrombocytopenia, grade 3 events ranging anywhere between 5 and 20%. And when you look at the ILD rate, you can see that the ILD rate with 5.4 is in around that range of like 7 to 8%. But grade 3 or greater ILD events are definitely less. And I think ILD is a very important toxicity of these agents, and you should have a really high degree of suspicion for that side effect. Any new onset cough, shortness of breath, it should not be readily ignored.
Subsequent to this recording, on April 5th, 2024, the U.S. FDA, for the first time, approved a therapy, T-DXd, that is now the first HER2-directed therapy to receive a tumor-agnostic approval in patients with previously treated advanced HER2-positive solid tumors.